Well, thank you very much, Dr. Botero, for this very kind introduction. And I also want to thank Dr. Santos for inviting me. So what I'm going to talk about is tumor treating fields for glioblastoma, as well as a little bit for other types of malignancies. And this topic is timely because, as everyone heard, as everyone know already, Senator John McCain has been diagnosed with a glioblastoma. As I was driving to work yesterday, I note one of the commentators posed this question. Since the death of Senator Kennedy, what has been new since then? And if you remember, Senator Kennedy passed away in 2009. So this is it. This is the new thing. So here are my disclosures. Now I just want to point out that glioblastoma is glioblastomas is just one of the subtypes of high-grade malignant gliomas. And as you know, there are other types, and glioblastoma is the most aggressive form. The median overall survival is approximately 1.5 years. There's a lower grade malignant glioma called anaplastic astrocytoma, and the median survival is about 3 years. The time to tumor progression is about 1 year. There are some variants, giant cell glioblastoma, patients do a little bit better. Gametoscytic astrocytoma, even though it doesn't have the aggressive features, clinically it behaves very aggressively. And the fibrillary astrocytomas constitute about 85% of all the malignant gliomas. About 10% of the malignant gliomas are the anaplastic oligodendrogliomas. And then there are these remaining 5% consists of mixed cell type anaplastic tumors, and they are called anaplastic mixed gangliogliomas, in which one part of the tumors has neuronal cells and the other part has malignant glial cells. We don't worry about the neuronal cells, we only worry about the glial cells because they can transform into a glioblastoma. The mixed anaplastic astrocytoma, the mixed anaplastic oligoastrocytomas has been dropped in the most recent updated WHO new classification in 2016. And primarily because of molecular markers, because the 1p19q molecular markers, loss of chromosome segments 1p and 19q, can resolve this issue because if they are co-deleted, then the tumor is an oligodendroglioma. If they are not, or just one of them, then it is an astrocytoma. The IDH1 mutation, it points to primary versus secondary glioblastoma. Primary glioblastoma refers to the most malignant form that occurs in older patients, whereas the secondary form occurs in younger patients. So what are the hallmarks of glioblastoma? So even though we can do these genetic markers, but pretty much all the malignant gliomas, they have these 3 hallmarks, and they are tumor growth, angiogenesis, and invasion. So this is a classic example of all 3 hallmarks of this tumor is in overdrive. And as you can see here, the malignant tumor is located in the left temporal lobe of the brain, and I just want you to pay attention at initial diagnosis after the surgery that there was no detectable tumor in the brainstem. However, when the tumor recurs about 6 months later, we see that the tumor at the primary site has enlarged, and there is fulminant angiogenesis. We know this because when we inject gadolinium, the gadolinium dye leaks into the tumor. And not only that, the tumor is highly invasive. It travels down the ipsilateral corticospinal tract and corticobulbar tract and start migrating to the contralateral brain. Now, notice that this MRI was taken back in 1998. That was before we start using temozolomide. That was before bevacizumab came into the picture. So these are inherent characteristics of glioblastoma. Now, why is it so difficult to treat malignant gliomas? Well, over the years, due to a number of genetic studies and also population studies, we know that there are multiple pathways that are mutated. So, for example, the PI3 kinase AKT pathway is there are multiple nodes that are mutated, as well as the P53 pathway, as well as the cyclin dependent kinase pathways. And even within one single tumor, when you do gene sequencing on individual tumor cells, you will see various mutated proteins within different tumor cells. There are some tumor cells that have EGFR mutations. There are some tumor cells that have PDGFR mutations, MET mutations. So the picture is highly heterogeneous. We have poor disease biomarker because we cannot track them. The only biomarker that we have is MRI, and we cannot possibly do screening MRI, just like a screening colonoscopy on the entire population, because every year there are only 19,000 cases, new cases of glioblastoma. And we certainly don't have a serum marker like a PSA that we can check in order to screen a large population. The blood-brain barrier is a problem because it excludes a lot of the drugs that are useful in other disease types to get into the brain. And the brain is also very sensitive to our treatment, so we cannot do massive resections. We cannot give very high doses of radiation because of certain limitations. And therefore, a lot of the times when the diagnosis is made, the tumor is pretty late in the clonal evolution, and resistant disease therefore develops. So this is just a chart in terms of documenting. I went into the FDA website to look at what are the drugs that are targeted therapies that are available in lung cancer, breast cancer, colon cancer, and compared to these disease sites, we only have one, and that is bevacizumab. So getting back to the hallmarks of this disease, the problems are there's no effective treatment against growth and proliferation. Anti-angiogenesis treatment using bevacizumab only offers temporary benefits because it prolongs progression-free survival. There's no overall survival benefit. And there's currently no treatment available to counteract tumor invasion. This is our biggest problem. So what do we have? So when we looked at the number of FDA-approved treatments for malignant gliomas back in 1996, Gliadel wafers were approved, and these are wafers that have BCNU in it. And it is implanted by neurosurgeons after a gross total resection. And even though this was done in recurrent glioblastoma population, in a randomized clinical trial, it shows an overall survival benefit, proving the point that drug delivery matters for this disease because of the blood-brain barrier. And later on in 2003, Gliadel wafer was approved for newly diagnosed glioblastoma. Temozolomide came in a little bit later. In 1999, it was approved for recurrent anaplastic astrocytoma, and not until 2005 when the international trial that incorporated temozolomide during radiation that we set a new standard. So since then, every newly diagnosed glioblastoma patients are treated with radiation therapy plus daily temozolomide during the 6 weeks of radiation. Now, bevacizumab was approved in 2009 because of the dramatic response seen on MRI, but I just want to say it parenthetically, bevacizumab this approval was not subjected to randomized phase 3 trial. It was approved based on 2 single-arm phase 2 studies. And in 2011, Tumor Treating Field was approved for recurrent glioblastoma, and a couple of years ago, Tumor Treating Field was approved for newly diagnosed glioblastoma. So in order to understand how this works, there are 3 domains that you have to build some knowledge in. The first domain is physics, and this encompasses computer modeling as well as this concept that is common in radiation oncology called electric field volume histogram, as well as the specific absorption ratio volume histogram. These are measures or quantitative measures of how much energy that goes into the tumor. The second aspect deals with the cell biology effect of this treatment, how the fields disrupt mitosis, how it sets up immunogenic cell death, and how the modulation of the immune system in our body can affect the outcome of this treatment. And lastly, I would like to point out some of the phase 3 clinical trials that are already done, as well as some of the future clinical trials in malignant glioma, as well as in other disease types. So we have been using energies in the electromagnetic spectrum all along in neuro-oncology, and Dr. Botero has pointed out very beautifully about how ionizing radiation can do for our patients, okay? So I'm not going to talk about that, but ionizing radiation is in this very high energy end of the electromagnetic spectrum. There are 2 FDA-approved treatments that are in the non-ionizing domain. One is called laser-induced thermal therapy, in which a neurosurgeon would drill a hole on the skull, put in a probe, and then use microwaves to heat up the tumor. And they can monitor how much the heating occurs using an MRI scan. And this is in the microwave range. At even lower frequency spectrum, the tumor treating fields, which is at 200 kilohertz, which is just a little bit under your FM radio, is currently in use. So this treatment started out with a basic scientific observation that was done in Haifa, Israel, in which a researcher was studying the biological effect of electric fields at this frequency, and he noticed that the cells are blowing up under the microscope. And as you can see, this is time-lapse radio. This clock is in hours, okay? And you can see that the cells blow up, and then later on, they subsequently die. And it took about 10 years to translate this observation into a bona fide FDA-approved therapy in which patients have to wear 4 transducer arrays, a pair front to back, and a pair side to side. They have to wear a battery pack as well as an electric field generator. The first generation, it weighs about 7 pounds. The newer generation, it weighs about 3 pounds. So the technology is improving. So let me just go over a little bit about the physics. Everyone in this room knows that opposite charges attract and same charges repel. So in a point charge, what happened is that the negative charge here would migrate towards the positive charge in a parallel plate. They would do the same thing, negative charge migrating towards the positive plate. However, in an alternating electric field, there's no net translational movement because the charges would alternate. However, in cells, a lot of the proteins are actually dipoles, and they have a dipole moment. So even though they don't have a translational movement, there's some rotational movement. When the field is inhomogeneous, then there's both rotational movement and translational movement. So the key point here is the induction of an electromechanical force. And you can actually go to your local children's museum, take your children or grandchildren and ask them to put their hands on the Van de Graaff generator, and you will see that their hair levitate because of the field that surrounds the patient, surrounds their head. This field is minute, but nevertheless, it is there. So when we first encountered this, that was in 2006, and that was when the when the phase 3 clinical trial was rolling out. One of the questions that my team posed was, would the field be able to migrate from the surface of the scalp through the skull into the tumor? And the answer is yes. We didn't need to do any work because it's already published in this paper. So when we looked at a frequency of 200 kilohertz, the permittivity of bone, gray matter, and white matter, as well as the conductivity of bone, gray matter, and white matter are essentially the same. Now, permittivity is a measure of a substance, how well it holds on to charges, and conductivity is a measure of how well the substance passes charges. And essentially, they are essentially the same, bone, gray matter, and white matter, suggesting that at that frequency, it is like light going through your living room window from outside into your living room. You can read a book in your house, you can go outside and read the same book, okay? So it is permeable to the electromagnetic field at this part of the spectrum. So when we do electric field modeling, one of the things that we see is that the field is very, very hot on the surface of the scalp, but when it permeates into the brain, because this is not like ionizing radiation, because ionizing radiation is so high energy, it goes through the brain in a straight beam, okay? So in terms of how to model it, how to map it, it is easier to map ionizing radiation than electric field, because when the electric fields goes into the brain, certain parts of the brain will summate, other parts of the brain it will cancel out. And what we find is that in certain part of the brain, like the horn of the ventricles, as well as in this part of the white matter between the lateral ventricle and also the tumor, the field intensity is extremely high. So this electric field mapping allows us to see where the field strengths are, particularly around the tumor. And this is influenced by both the property of the tumor, the property of the brain, as well as the geometry of various structures within the brain. And we can actually construct a dose volume histogram. So in ionizing radiation, that's what radiation oncologists do. They look at the dose volume histogram and estimate what is the dose that goes to various structures within the brain, and they want to avoid parts of the brain that are sensitive to ionizing radiation and other parts of the brain that are not so sensitive to ionizing radiation, and they certainly want to maximize the energy that's deposited into the tumor. And likewise here, the dose on the dose volume histogram, we can see how we can measure the amount of energy that's deposited into the tumor. So how does it work on a cellular level? I just want to point out that the fields work in a very, very different way from other types of anti-cancer modalities. So as you probably know, most of the DNA damaging agents that include ionizing radiation as well as cytotoxic chemotherapy, they try to trip up the G2 and M checkpoint to generate an apoptotic response. Taxol is a different drug that primarily acts within the metaphase that triggers the spindle assembly checkpoint. And tumor treating field actually act at a time point in mitosis that is past metaphase, in anaphase as well as in telophase. So some of the proteins within a cell that have very, very, very high dipole moment participate in the cytokinetic process. So cytokinesis is a process in which that occurs at the end of metaphase and at the beginning of anaphase when all the chromosomes are docked at the metaphase plate. As soon as the sister chromatid splits, then the cytokinesis occurs. So there's this very, very large protein called septin in which its dipole moment is 5 standard deviation away from the average dipole moment within the cell. And what happens is that this electric field can disrupt septin and then eventually make the cells sick. They either go into apoptosis or make them sick enough that, some of the acute phase reactants like calreticulin goes to the cell surface, or some of the heat shock proteins go to the cell surface, and together with HMGB1 participate in the process of immunogenic cell death. So this is normal mitosis. Everyone in this room would know that. You can show this video to your children in 8th grade or in high school. They will tell you exactly what this is. So as soon as the metaphase plate splits into two, the cytoplasm also starts to split into two. However, under the influence of too much treating field, as soon as you see that the metaphase plate splits, the cell goes into this violent blebbing phase. So the cytoplasm cannot split into two, okay? So, and there are certain cells that can potentially split into two, but they have asymmetric chromosome segregation. So this is a DNA dye on the right-hand side. So the cell on your right has more DNA content compared to the cell on your left. And also the mitotic plates can sometimes be disrupted. And in basically every cell type that we tested, calreticulin can go to the cell surface. So this is true in MD8 231 breast cancer cells, MCF7 breast cancer cells, as well as HCT 116 lung cancer cell lines. And it sets up endoplasmic reticulum stress, so the cell is stressed and mark the cells for immunogenic cell death. So these are the physics and cell biology mechanisms, so I will talk about what are the clinical trial data. There was an initial safety study called EF07. This is basically a pilot study in which 10 patients with recurrent glioblastoma were treated with just the tumor treating fields, as well as 10 patients with newly diagnosed glioblastoma were treated with just tumor treating fields. And after that, because of the favorable progression-free survival and overall survival, EF11 phase 3 trial was designed, and then EF14 phase 3 trial. The METIS trial, EF25, is ongoing right now for non-small cell lung cancer brain metastases. There are also other trials that are being done in Europe. So these three, PANOVA, INNOVATE, and STELLAR, they are being done in Europe on pancreatic cancer as well as ovarian cancer and pleural mesothelioma. STELLAR trial, LUNAR trial, excuse me, is a phase 3 clinical trial for as a second-line add-on treatment for systemic non-small cell lung cancer, and it is being planned and will soon roll out. So the phase 3 clinical study in recurrent glioblastoma went like this. So it started in 2006 and it ended approximately 2009, 2010. It was a randomized 1-to-1 study in which half of the patients were randomized to the tumor treating field as a standalone therapy, and the other group received whatever the treating neuro-oncologists think that is the best chemotherapy for this population of patients. It was an international study. The primary endpoint was overall survival. The secondary endpoints were progression-free survival, 6 months progression-free survival, 1 year survival, response, as well as quality of life. So the population, the patient characteristics were pretty similar. The age were in the mid-50s. There were more men signed on to this protocol than women, and obviously, I mean, we had to shave their hair, and it is more acceptable for men than women. all of the patients had glioblastoma, and I just want to point this out, about 40 to 50% of the patients were on dexamethasone in this population. And the tumor treating field population had slightly bigger tumors, and the interval from initial diagnosis to entry into the protocol was about a year. Now, it is also important for me to point out that roughly about 40% of the patients were in their third or greater recurrence. Now, in a lot of the neuro-oncology trials, the trials did not want patients at second recurrence. A lot of the trials, they only want them to be at first recurrence. About a third of the patients had debulking surgery, and they had the typical radiation, and about in the middle of the trial, bevacizumab was approved, so about 20% of the patients had bevacizumab in the control arm. So this was the trial result. The overall survival were pretty much the same between the two groups. They were comparable. The median overall survival was about 6.6 months in the tumor treating field monotherapy group compared to 6 months in the control group. The median time to tumor progression was about 2.2 and 2.1 months. So tumor treating fields was comparable to standard of care chemotherapy. Now, the results, the phase 3 clinical trial results was a little bit of a shock because in the EF07 trial, the initial pilot study, the median progression-free survival on those 10 patients were 26 weeks, and the overall survival was 62 weeks. They were very, very good, okay? So we start asking the question, why was it, why the result was so good in the pilot study, but we were only able to show a comparable effect in the phase 3 randomized study. So the easy question is patient selection. We selected out the most favorable patients in the pilot study, okay? That is true across the board in neuro-oncology trials. However, if you think a little bit deeper, what kind of patients were selected? That was the harder question. So we immediately asked the sponsor to give us the primary data, and my team was trying to dissect it out. So one area that we started looking at was the responders. What made the responders respond to this therapy compared to the non-responders? So there were two things that fell out in that analysis. The first thing was that patients with secondary glioblastoma have a higher rate of response, and also the dexamethasone dose matters. So in this analysis, the dexamethasone in the responders was substantially lower in terms of the daily dexamethasone dose as well as the cumulative dexamethasone dose. And this also goes with the chemotherapy group in the daily dexamethasone dose, but not in the cumulative dexamethasone dose, primarily because I think there are not that many responders in the control arm. So that was only in responders. Then these two factors, we cannot modify the genetic background of the tumor. However, we can modify the dexamethasone use on patients. Okay, therefore, we went back again into the data and tried to analyze the dexamethasone dosage used across the entire population. And what we found in this unbiased post hoc analysis was that patients who were on a higher dexamethasone dose, well, how high are you talking about? The cutoff is about 4.1 milligram per day of dexamethasone, and you can see that patients treated with tumor treating field monotherapy, if they are using less than 4 milligrams a day of dexamethasone, their survival is about 11 months, versus those who use more than 4 milligrams a day, and that was about 4 to 5 months. And that is the same for the chemotherapy group as well. and the chi-square was in the 11 and 13 range. It was pretty high. Now, this is not because of tumor size. And when we compare the tumor size of the two groups in each of the cohorts, there's essentially no statistical difference between the tumor size. So what does that mean? That means that clinicians are not paying attention to how much dexamethasone patients use. Patients are euphoric when they take dexamethasone, but it's only when they take dexamethasone for 3 months, 4 months, then their body starts to fall apart. They get immunosuppression. And now with immunotherapy, we have to be very, very careful about how much dexamethasone that we use. So EF-14 trial is a trial in which we compare tumor treating field plus temozolomide versus temozolomide alone after radiation and daily temozolomide. So the randomization is about 2 to 1. About two-thirds of the patients randomized to the experimental arm, tumor treating field plus temozolomide, whereas 1/3 of the patients randomized to the temozolomide alone arm. And the primary endpoint was progression-free survival, and the secondary endpoint was overall survival, and there are other endpoints as well as quality of life, response, 1-year survival. So the patient characteristics were roughly similar. The MGMT status were well-balanced. The IDH1, whether or not these are secondary glioblastoma versus primary glioblastoma, were well-balanced. The corticosteroid dose, because we are talking about newly diagnosed patients, we have a lower proportion of patients who are on dexamethasone, about 30%. And about 75% of the patients adhere to the prescribed dose of tumor treating field. And the median age were roughly similar as in the recurrent trial, in the mid-50s. And again, men tend to adopt this therapy better than women because of it requires shaving the head. There are more patients with a gross total resection, and the median time from diagnosis to randomization is about 4 months, and the duration of temozolomide was about 5 to 6 months, and the duration of tumor treating field was about 8 months. So there was a planned interim analysis that occurred about 18 months into the trial, and the final analysis, final 5-year analysis just came out earlier this year. And the result is essentially the same, in which there was a progression-free survival benefits from about 7 to 8 months to about 11 months, and there is also an overall survival benefits from about 19 months to 24 months. And the toxicities are also comparable. They are toxicities primarily from the temozolomide chemotherapy, with a drop in blood counts, and these are grade 3 and grade 4 toxicities. They are comparable. GI toxicities, they are also comparable. Fatigue, they are also comparable. Infections complications and also procedural complications, they are not that different between the two groups. And one of the questions is whether or not this therapy can trigger seizures. And initially, when we were doing the recurrent glioblastoma trial, my institutional review board actually required us to house the patient in the hospital for the initial 24 hours, and there was no increase in seizure activity. Neurological disorders are comparable between these two groups. So to summarize, tumor treating field and chemotherapy have comparable efficacy when tested in recurrent glioblastoma patients. Scalp irritation is the common side effects of tumor treating field, and that can be managed with topical corticosteroids. Dexamethasone use, we have to be careful about that because depending on the dose, it may influence patient survival. tumor treating field plus temozolomide is superior to temozolomide alone in newly diagnosed glioblastoma patients. The side effects are comparable in the two groups and consist of primarily hematological toxicities. Now, I will go into a little bit about what goes on in brain metastasis. So since the approval, there has been a number of investigator-initiated trial in using, in terms of combination therapy, the most common combination is with bevacizumab for recurrent glioblastoma. I just want to point out that this METIS trial that is ongoing right now for non-small cell lung cancer brain metastasis, and this is not for those patients who can benefit from targeted therapy. So it's basically boils down to a selected population. And as far as the systemic therapy is concerned, LUNA trial for advanced non-small cell lung cancer as a second-line treatment with, together with anti-PD-1 therapy or paclitaxel is soon to be rolling out. And there are also other trials for pancreatic cancer, ovarian cancer, and malignant pleural mesothelioma. So thank you for your attention. This is our research team. I had the clinical research team, but I also interact heavily with the cell biology research team at my institution, headed by Ken Swanson. And he's a cell biologist and immunologist, as well as the multiphysics team headed by Edwin Locke. So thank you very much.